All right, welcome for our Q&A, Wednesday, June 4th. Dr. Wong, Simon's here, lunch break. This is Q&A during his lunch, so let's get started. We have some questions. Simon, do you want to share your screen? You got the Google Doc? I think I sent it to you, right?
Yes.
Some questions came through.
Can you see my screen? Hello? Okay, just double checking that everyone can see my screen.
All right. So, yep, Dr. Dutton is joining. He's got some questions. Welcome, Dr. Viet and Manisha. All right, can you hear, Simon?
Yes, you can see my screen. Hello?
Everything okay?
Can you hear my screen? Can you see my screen? Hello?
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 Can you hear me? Okay. Can you hear us okay?
Hello?
Yes, can you hear?
I can hear you. Can you hear me?
Yes, it's good. Go ahead.
Okay, all right. So, some questions. First question is regarding chewing exercises. Are we asking them to alternate the chewy from side to side, or do we want them to chew bilaterally at the same time on two different chewies? And are we doing this to strengthen and coordinate the jaw muscles only, or is there another reason to do these exercises? And is it okay to do these exercises if their bite isn't lined up correctly? I'm assuming, for instance, because they are being expanded and everything is changing. For instance, what about in a posterior cross bite case? Do you have them only do chewing exercise on the good side, or do you wait until the posterior crossbite is at least corrected? I know you say you don't have class 3 anterior crossbite cases do exercises until the crossbite is corrected, but what other contraindications to any of these Verpex exercises? So crossbites, whether they be anterior crossbites, posterior crossbites, class 3 crossbite, or even a class 1 crossbite, we don't do any of the exercises until the bite relationship is not going to traumatize the TMJ. Expanding is during the expansion phase. So long as they're not in any form of a crossbite, we can do the exercises. The bite is disrupted in the expansion, which is why we have the bite ramps in place to allow for the differential expansion between the upper dimension, which expands at approximately 0.8 millimeters per 8 days, versus the lower expansion rate, which is only 0.35 millimeters per 8 days. Because of that differential in the rate of expansion, we will see a physical scissors bite open up, but because there are bite ramps on the palatal side of the upper appliance, this compensates for that and allows the bite relationship to still function. As far as the chewies are concerned, we just use one chewy. We just chew 30, a few times, 30 times on one side, then we switch over to the other side. And we're just using those as a means of building strength for children who are especially low in muscle tone. Okay, next question. I do not understand the half turn on the screws. When you say turn the screw back 4 times, for instance, do you mean 4 half turns? In other words, does every time you say the word turn mean you are referring to a half turn of the screw? Right, so a half turn is a term of convenience for the parents. In order for them to understand what we are trying to ask them to do, we utilize the arrow, which is on the screw housing, to indicate, firstly, the direction of the turn and the amount of turning. Obviously, there's an arrow head and there's an arrow body. We're trying to train them to turn half the arrow per rotation, right? Which works out to 45 degrees of a full turn. For the doctor, the concept is every time we make a turn, it's 45 degrees. We are referring to each 45-degree turn, which of course corresponds to half the distance of the arrow. And so it's a little bit confusing, of course, because we're conversing both with doctors and with parents. The half turn nomenclature is meant to allow parents to know how much to rotate each time. The assumption is the doctor knows that each turn is half the arrow or 45 degrees. 3, can you give an example of how I would verify how many times parents have turned the screw by turning it back? Give me a few different examples of what I should see versus overturning versus underturning. The example is if you have not seen the patient for 2 weeks and they come back and they have had instructions to turn the appliance every day, you will have the screws opened up and there'll be a separation between the 2 halves of the appliance. You will reconfirm with the parent if they have, over the last 14 nights, turned the plate screw, the half turn, or the 45 degrees. If they say, yes, I've turned the screw every night and I've done half the rotation that's possible in the appliance, which is 45 degrees, which is half the arrow, then you'll say, fantastic, let's count back and see. And then you will rewind the plate in 45-degree increments or half the arrow and count it back. When you have finished the count back, assuming that they started with no separation in the screw, you should find 14 45-degree rotations backwards, 14 half turns, or as far as the parents are concerned, and 14 45-degree turns as far as the doctor is concerned. If, however, when you rotate back, you count in terms of 45-degree backward rotations, they've done 28 rotations of 45 degrees, then you know that instead of doing a half an arrow, they've done a full arrow, which is 90 degrees. Alternatively, if you rewind in 45-degree increments or half the arrow, that they have only turned 10 turns in total, 10 45-degree rotations. Then you will say, have you missed any nights? And then they'll say, oh, I forgot to mention the long weekend we didn't do any turning, whatever. So that will give you an indication of overturning in the first instance when there is more than 14 turns in that 2-week interval, or 14 45-degree rotations. Or if they've done less, 10, 6, 2, none, then they will have underturned. The videos that I have included in my program illustrate this graphically. So please review those videos. 4, if we are expanding correctly, about how much space should we see between the plates on the upper versus lower each month? Or do you go by weeks? I feel like my brain, to not get lost in the weeds, I need to write down how much I expect at the next visit and then have a very reliable system to measure whether or not they're on track. So the expansion rate should be 0.8 millimeters every 8 days on the upper and 0.35 millimeters every 8 days on the lower. You are welcome to measure the gap between the cut plates. The two halves of the plates usually the acrylic component is in contact initially, perhaps a 0.5 mil separation where the saw cut began. And then you can measure the width of separation. If you feel that is appropriate for you, then you can calculate 0.8 millimeters every 8 days. So you can do the maths, work out every month. There are 30 odd days in the month. And then you can work out how many millimeters of separation you should expect. We should be seeing approximately a gain of 0.8 or close to 1 millimeters every 10 days or so. That helps you in the upper, and about a third of that in the lower. All right, so every month you should expect about 1 millimeter in the lower of expansion, and every month you should expect about 3 millimeters of expansion in the upper, if that helps you. How much does each screw expand? Generally, how much space should I see between the plates when we're done expanding? The upper screw, depending on the screw that is used in the mouth, but generally the screws are 8 mil, 10 mil, or 12 mil. The most commonly used is the 10 mil screw. So it will max out at approximately 10 mils, although generally by the time you hit about 8 mils, the screw will start to fail and it will become very loose and not expand willingly or easily. In the lower, it's a 5 mil screw. So when you get to about 4.5 mils of separation between the plates, the plate on the bottom will run the risk of completely falling apart. The upper doesn't fall apart, but the lower falls apart. So the upper is limited by the screw failing to expand further beyond 8 or 9 millimeters, and the lower will continue to expand to about 5 mils, and then it will completely fall apart. So you've just got to monitor those measurements, about 4.5 mils on the lower and about 8 mils on the upper. That will tell you that the screw itself has reached its maximum capacity. How do you get the white background on your pictures? The wall that I have my patients stand against for the photography is white or cream in color. If you don't have a wall that's white or cream in color, then you can get a white backdrop, or you can paint a segment of the wall white or cream. The better the light exposure through the use of auxiliary lighting, whether it's down lighting or the auxiliary flashes, will also ensure that the background, which is either white or cream, will have a very white or very light cream presentation. When you underexpose, doesn't matter what color the wall is, it will look gray or darker. Alternatively, you can have a light box, a background where there is backlighting, which creates a pure white, radiating white coloring in the background. So the section I have on photography goes into more detail about this in the phase 1 lectures, but if you look at my surgery clinic office setup in the introduction course, you'll see that my photographic setup, coloring of the walls and the lighting that I use to achieve my outcomes. 7. How do you treat cats in the how do you treat cats in the maxilla? Do you have them chew more on the low side, for instance? A lot of the canting tends to unravel as we expand. That's just been my experience. I don't specifically worry overly about cats, as in my experience, as I expand, the cat seems to resolve. The most common etiology for cats is that one border of the tongue being held between teeth on one side. Most often because the transverse width of the arch is insufficient for the tongue to be comfortable between the molars. When we have developed enough transverse and retrained the children to rest tongue between the teeth in the arch form, a lot of the etiology disappears and the teeth tend to erupt back into a better alignment. 8. I'm trying to learn how to bracket anterior teeth. Can you please tell me what bracket system and supplies I need to purchase to get the results you want? I understand there are different prescriptions in each bracket. So there's many different systems available. There's many prescriptions. I tend not to get too involved in specific recommendations. We don't tend to have to be as particular in the talk relationships. We're usually only bracketing teeth to tidy up and align in rough dimensions the incisors that have erupted, like the lateral incisors, if they've erupted a long way out of the general arch form. I personally tend to use Roth brackets. I don't use the self-ligating ones generally, just a basic Roth bracket that is 4-tie. And we just use elastics. We don't have any specific prescription other than we have to make sure that there's no clashing of the bite against the lower brackets, and we bracket the upper 6 front teeth, including the primary canines and the 4 incisors, to try to level and align the curve of spay. So sometimes you have overrupted teeth and bracket the permanent teeth close to the incisal edges and the primary canines close to the gingival, and that will act as a reverse curve, so to speak, in the alignment process. We don't run a lot of focus on torque. We're effectively just controlling torque with the combination of the cat wire behind and usually only light round wire night tie and rectangular night tie up to about 1825 to help me with the alignment and any chain retraction to close unwanted spaces. So this is a very basic system. When I have students join in the advanced mentoring, then I go into specific details about which companies will give the best value for money and which brackets that are available to each doctor based on their local situation. So we have doctors who practice in Europe, we have doctors who practice in Australia, we have doctors who practice in the United States. So access to different systems varies. We don't have the specific detailing needs of a phase 2 orthodontic program. So it's just something simple, something cheap, is all we need for the phase 1 type of tidy ups. Next question regarding GoFX and retention phase. So now I understand that you keep the plates until the ease falls out so the 6 is going to move forward to close the leeway space, unless the canines are up on top of it. Then you rely on the GoFX to hold the developed space and act as retention. Question is, if you finish expanding well before the ears will fall out and you make an upper retainer, lower retainer, how exactly do you perform the GoFX exercise? Do you perform the swallow and tongue exercise with the retainers in or out? For example, do they take both retainers out to do the exercise and then put them back in? And then continue doing this until the ears falls out. Then get rid of both retainers and they are on their own now. So we plan our retention based on the life expectancy of the ears. So it depends on when you actually start the treatment. If you start very early intervention and you finish your active expansion and development, and there are many, many years remaining in the life of the ears, so say you finish before 8 or even 9, then you will want to hold the changes with a retainer. And that retainer is worn at night. It's not worn during the day. So when you are having the patients practice GoFX, they are practicing during the day and they don't actually wear the retainer during the day. Now, in the initial retention phase, when you have finished the active expansion, you can have the option of making the retainer before you start training them to do GoFX, or you have the option, in which case they will wear the retainer full time until they have mastered the GoFX. All GoFX exercises are done without appliances. All GoPEX exercises are initially done with appliances. GoPEX is designed to train lip and cheek and elevator muscle control. So having appliances in the mouth does not preclude children closing their lips and biting their teeth into a centric occlusion or maximum intercostation. They can't do GoFX when they are wearing appliances full time, especially during the expansion phase, because GoFX is about tongue control, and the tongue is actually blocked from doing its correct position when there are appliances in the mouth. So GoFX can only be learnt when we have finished the arch development, we have a reasonable occlusion, natural centric that has some form of good stop positionings. Then we take the plates out and we practice the tongue control, which is effectively learning to swallow with an adult physiologic swallow. When we are learning the GoFX, whether in the existing stage 1 appliances or the new retainers, we take the plates out and we practice the exercise, and then we put the plates back in. When we can demonstrate good tongue control and that we're swallowing with the adult physiologic swallow, then at that point we can move to a part-time wearing of the retainers, which is the evening and nighttime phase of retain. And then we continue to practice swallow using GoFX during the day, at which point we're not wearing any form of retainers. The retainers have a very thin profile, so we should still be able to swallow correctly and hold our teeth into reasonable occlusion, even with the retainers in place. As far as when we finish retainers, generally when the ears fall out, we are in need of allowing leeway space to close in order for the 12-year-old molars not to be blocked from erupting. And 10 is when will I learn to manage the Bolton overlays and the meanings of the colored lines in the PowerPoint? Well, I'll learn this as I load my cases. So we go through the setup for the PowerPoint in the advanced phase 1. And we have a thorough explanation of how to do that included in that program. And then for those who join the advanced mentorship program, then after you've spent time practicing, I will help you in each of the sessions to correct any errors and to help refine your techniques until in time you'll learn to do it on your own without assistance. But the instructions are part of the advanced program, and I step in to help tidy up any errors during the mentorship program when the cases are uploaded and you've had a go at trying to put together the PowerPoints. So that ends the current series, but I think last week there were a few leftover ones, so I'm happy to go through those as we have a few minutes left. So there were 2 remaining questions from last time. During your expansion, what are you looking for when you equilibrate the primary dentition? Are you marking with articulation paper? And if so, what jaw positions are you using for your reference? In adult dentition, I understand the concept of adjusting occlusal interference to centric relation position, but I cannot seem to wrap my mind around the primary dentition by adjustments unless there's an obvious canine in which causes the jaw to deflect off the center, for example. So at the end of the arch development phase and the incisor tidy up phase, like all dental relationships, we are aiming for a centric that has fairly even contacts on both sides with no prematurities, and we want some general sense of guidance. In the mixed dentition, guidance tends to be less of a reality because there's so many teeth changing over, but in naturally good growth, there's always fairly solid centric relationship stops everywhere and evenness in the bite. The sixes tend to be socked in nicely. The primary molars tend to be socked in nicely. When we are equilibrating, we are trying to aim to get really nice, level, even contacts in the primary dentition, much like most children have when they are not interfered with orthodontically. So nature has an ability to compensate dental alignment to allow, even in very poor occlusions, skeletal-based occlusions, there's usually some relative evenness in the bite. Right? So it doesn't matter how bad a malocclusion someone has, generally they can still bite with fairly even contacts in centric. They may not have guidance, they may not be free of lateral interferences on excursive movements, but in the up and down centric, they usually have even contacts all around the mouth. So we're trying to aim for that. So we're trying to get them without appliances to bite into their centric, which you have tried to equalize through expanding in both the upper and the lower arches. We use articulation paper and we look for any prematurities that are stopping that general reasonable balance of primary dentition centric balance. And any of the prematurities that are evident in the articulation paper, if it's in the primary dentition, we take a burr out and we grind the high spots down until we get as close as we can to a balanced centric occlusion. We don't equilibrate permanent teeth in this mixed dentition or primary dentition equilibrium process. We're only adjusting primary dentition teeth to get as many even contacts in centric as possible at the end of the treatment. You don't worry too much about excursive protection or canine guidance because that actually doesn't happen until the adult dentition is socked in. So we're only aiming for reasonable balance in the centric relationship, the up-down bite position. So we're looking for, often that will come in the form of cusps that are unworn because there are teeth that haven't had any loading, or sometimes teeth are tipped as an adverse side effect from the expansion, and sometimes we just need to level out primary cusp tips that are interfering with the bite. The better control you have in both upper and lower expansion using the appliances, the better the children have followed the GOPEX process, the less equilibrations you'll find you need. If you haven't paid attention and the plates have not been retentive, or the rate of turning hasn't been good, and especially if they haven't done their chewing exercises, you'll find at the end of the expansion rate, things don't quite line up and the child has lost the natural centric relationship, and they can't find a bite that's comfortable, and often there's prematurities in individual teeth that are causing functional shifts, and that's basically when you want to equilibrate. All right, equilibration often is trying to patch up some of the adverse effects that have crept into your treatment because you haven't understood what is needed in the protocols to create a stable bite throughout the entire process. One of the most important things we're aiming for is a stable centric bite relationship, which is why we have things like bite ramps in the palatal region to allow for the fact that we have differential rates of expansion, and why we do GOPEX to keep constantly creating a natural leveling of any cants. And we also are looking at using the equilibration to deal with any unworn cusps and any adverse effects that we've missed in checking for solid retention, checking the rate of expansion, coordinating both upper and lower expansions. All right, just one more question, so I'll finish that off before I head off to what's left of my lunch. What appliances do you use now in your 4 to 10-year-old postural orthodontic cases? You use stage 1 for upper without occlusal coverage, Wong stage 1 for lower, and then retainers. I still don't understand the design of your retainers. Any other appliances? My vision has always been to somehow treat early and non-invasively as possible. So I'm trying to visualize the ideal case scenarios and start looking at my patients through that lens first. Then I'll know which ones deviate too far from, so that not to bite off more than I can chew. Yes, so in postural orthodontic cases that are mild to moderate in their malocclusion, their skeletal malocclusion, I'm using the stage 1 appliance for the upper with the bite ramps on the palatal side, but not covering the occlusion. Stage 1 lower, absolutely, so that we can coordinate the widths of both the upper and lower arches. And then the retainers are basically the same types of appliances without the bulky screws in place. So we designed the retainers to either be effectively those appliances with less bulk in the palate and the floor of the mouth. And sometimes the retainers have wires that are an active component to help tidy up the incisors that are perhaps still erupting, but out of their correct relationship in the arch form. So retainers are varied in their design according to what teeth remain, what teeth are stable. If we're trying to maintain some space for teeth to come through, if we're trying to hold space, if we're not trying to hold space, if we're trying to tidy up permanent teeth. So the design varies quite dramatically depending on the age of the child and what teeth are remaining, and what teeth are in alignment and what teeth we want aligned. So the retainers have, in many cases, an active component. So sometimes they call active retainers, so that they hold the space and they help tidy up incisors, so that they become what we call active. And sometimes we're holding space and we have ectopic premolars erupting, and we have an active component that helps us distalize a premolar that's trying to eat into a canine space, for example. Okay, so that's why it's a bit confusing, because it has to be designed case by case, patient by patient. All right, so it's a custom design. All right, so that
All right. Thanks, Simon. I know you got to run off for lunch. And all right, for those who are joining this weekend, you can sign off. I'll just say goodbye to everyone. Thanks. So, Dr. Dutton, yeah, I think you'll be if you can join this weekend. We're starting at 2 p.m. Pacific on Friday. This is for our 6th annual 2-day intro to postural orthodontics. So we just do this once a year. We've just been doing it for once a year. And our big event is this weekend, Friday, Saturday, 2 p.m. to 9 p.m. Pacific. Registration at 1:30 to 2 if you want to get the CE. You need to join then. We've got some instructions on how to do all that. Otherwise, we'll start sharp at 2 p.m. Pacific. Dr. Viet, if you're there, more than welcome to come as a guest as well. You were a past student. We had extended some complimentary tickets, but if you're interested, just send me a message. Actually, I'll let you talk. Actually, you've got questions. Dr. Viet, are you there? It's just a couple of you guys today, so um, if you have any questions about the weekend event, if you want to attend Dr. Viet, let me know and I'll send you a complimentary ticket as a special. You've been joining us on these weekends, these Wednesday calls. So if you'd like to join this Friday, Saturday, let me know.
Thank you so much, Mr. King, and thank you so much for Dr. Simon for today's class. It's very interesting.
Yeah, I just to put it into context, Dr. Dutton is joined our mentoring.
Yeah.
So she submitted these questions, which are very specific. And are you there, Dr. Dutton?
I am.
Yeah, hopefully those questions were answered satisfactorily. I popped out for a little bit. Did Simon answer the question about the Bolton
Um,
and the meanings of all the colored lines? Because I did send you
no,
the link. They didn't answer that question?
no.
Oh, that's strange. But I did send you, we do have the Bolton overlay. Did you know where that is? And where we, in phase one, in the advanced phase one, let me just share my screen quickly, if I may.
I'll have to go back and look at it. I've been going through all the stuff pretty
Yeah, there's
voraciously. But
yes, no, there's a lot that there's a lot that was covered, so it's good to revisit. And let me just bring up the link that I sent you. Just bring up this link. Yeah, here we are. So I know you're out of town this week, and you mentioned, but the recordings will be available within a week.
yes,
It's not going to be that much different from what you went through It's not as critical. I think you got so much stuff to get through, right? Yeah, this is the Bolton overlay. It's in the phase one handouts.
okay.
All right, so it's in here. This is and here it is. You got the different overlays,
Yeah.
and then like how to read them properly. You know, I think that was covered in phase one in the curriculum. But then you can double check with Simon.
I've got those. So I've been already starting a bunch of PowerPoints, grabbing patients and putting them in there, but I just exactly how to manipulate it is where I'm going to run into it. It takes so much time. So I just don't want to waste time. I'd rather be shown, okay, this is where you're trying to line up the forehead and the nose and
All right.
show
So
me
if you're
eyes
having
spots.
trouble manipulating the photos into the Bolton thing, is that right?
No, having trouble once I get my photos in, trying to size it because you have to size and rotate that Bolton
Yes.
standard and match it to the face properly. That's it.
Yes. Yeah. So this is another handout that Dr. Kevin Boyd gave. Um, so I'll send that to you. This was from last year's event, and
Yeah.
he gave that as an extra bonus. I'll send you this one as well. Has some instructions on how to move things around or whatever. So
All right.
let me send that to you. Let me just send that to you now. Yeah, so if you got to rush off, but I will. It was an extra bonus, so some of you might have missed that. Um, yeah, I'll message you with that. But one thing that let me quickly do, otherwise I'll forget. And so yeah, it's fiddly, but you got to learn how to manipulate and just practice. That's all it is. It just like anything. Um,
Hmm.
But if it's just, yeah, this will give you some further instructions or from Dr. Kevin Boyd.
Hmm.
I'm sorry, I kind of lost my voice. Here it is. Okay, I'll give you this Dropbox link, and you can download it. I'll just text it to you.
Or
It's-
yeah, email even better because
does-
email I can transfer it.
Oh, okay. I will email it to you now.
Great.
I know, yeah, you've kind of fire hosed everything in just a few weeks, so that's amazing. So just, join us on these calls, and not this weekend, obviously, but the next weekend you'll be again joining the mentoring.
Okay.
How did you find the first session?
No, it was great. Yeah, he's very strict. So
My older brother.
yep. So yeah, it's probably the only way to do it and get it right and be efficient. So it's just for those of us that are older than 40, that I find that the technology is very difficult to learn how to do. It takes so much time. So
Yeah, it's
that's my
fiddly.
biggest
It's
struggle.
not. Yeah, they hang in there. It's like with anything, just going to persist a little bit, but it's not that many things to learn technologically in terms of photo manipulation and PowerPoint stuff. But once, give yourself a few weeks and of playing around with it, and perhaps ask some of your staff members to help out a little bit, or but you'll get the hang of it. Just like with
We've been
anything.
working on it, and I have two patients that were referred, and they'd already gotten their records done by another dentist. So I'm trying to take their records and
Mm,
trying to, manipulate them and get them properly into my records, so that, Ceph, Pano, and
mm-hmm.
I don't want to radiate the child again, and there's CBCT images, and that's turning out to be a time suck. So as far as, do I charge the parents more to not take my own records?
Yeah.
Because I just don't have the time to sit there and figure out how to manipulate them. Even if it wasn't
Uh,
for Simon's course, even just for myself, it's
yeah.
time
Yeah.
consuming.
Sure. Maybe get some advice on that on the
Yep.
next session.
Okay.
Yeah, so thank you so much, Dr. Dutton. See you
Thank
shortly.
you.
Thank you.
Okay.
Good night. Dr. Viet, did you want that? Well, anyway, just send us a message if you would like to join this weekend.
Yes, I
Um,
will. Thank you so much, Mr. King. Thank you so much to Dr. Simon as well.
yeah, you're welcome. You're welcome.
Thank you.
So, unfortunately, we just wrapping up here. I know there was just another person join, Malika. Let me just, is it Malika? Melika? Is that Malika? Just
Hi,
allowed you to.
yes. Sorry, I totally missed the webinar.
No, that's okay. We recorded everything. So I'm going to upload it in the next day or two onto our YouTube channel. So yeah, there was a lot covered. A lot of the questions came from Dr. Dutton out of California, who's joined our mentoring program with Dr. Wong. So it may be a little bit more advanced, but we do have a lot of free training on our YouTube channel, which I'll quickly just show you where that is. I think you mentioned you were pediatric on the questionnaire once that you filled out when you joined our mailing list. Is that correct?
Yes, that's correct.
Yeah, terrific. And you have an interest. So this is the YouTube channel where you can get, we say 5 hours of free training. Excuse me, my voice is a bit crackly. It's like 6 or 7 at least. It's like almost a day's worth of training. We have every year we do a 2-day intro program. And it's part of a virtual residency program that my brother's developed, Dr. Simon Wong. I've been his business partner for 6 years on this. I'm his brother out of New York, and he's based out of Australia. And we've been teaching, over 500-600 dentists the last, few years on his method of early interceptive protocols using removable appliances and this kind of myofunctional type of exercise called GoPEX that he developed, good oral posture exercise. But if you want a sense of what it's all about, we've uploaded pretty much like a whole day's worth of training. There are different excerpts from different paid 2-day events. So if you just go to this link here, did you get a chance to review this when you opted into our website? I just
No,
was
but I
curious.
will look into it. Thank you so much.
Yeah, that way I know people are so busy these days, but we put a lot of free stuff here. Our 2-day program, just so happens it's coming up this weekend. In the off chance you're interested, just let us know. We've got some specials on the pre-sales of the recording of the event. I know it's probably last minute to join this weekend, but it's 6th and 7th of June, but the recordings are quite well discounted. You can see on our website that it's instead of whatever it is. Last year we held it in New Jersey, and the ticket, we had VIP tickets, standard tickets, live stream tickets. This was held at near Newark Airport. My brother flew in from Australia, but this year it's just on Zoom. So there's a lot lower costs doing it on Zoom. It's just a day away, but so the ticket prices are much less. You can get the recordings for just like $700 until the end of June, I think. Oh, sorry, until it's a pre-sale because we haven't got the recordings until effectively this weekend editing. So another week or so. So that's just a special we have. It's normally about $997. But anyway, if you want the free stuff, it's all here. We include, people, why are you giving a day's worth of training for free? It's a 2-day event, but the 2-day also comes with very detailed protocols. So there's like 500 pages of templates, slides, and practice templates you can modify, put your logo on it and stuff like that, right? So that's included as well. But if you just want to kind of get a sense of whether this is something worth pursuing, then binge watch all the free stuff first and go from there. And we do have advanced training. Up front we tell people, look, if you're relatively new to early intervention orthodontic type of stuff, then check out our advanced program. We give away 10 hours of free access to our advanced training. There's hundreds and hundreds of hours of training if you really want to get into it. Just like any specialty, you can go to university for a year or two for a specialty residency, or you can do an online version. We have, for example, all the free stuff. If you go through here, you can see a sample of lab day. So we spent a day. These are just removable appliances that my brother developed based on different experts in the past. Professor John Mew, he modified his BioBlock. It's a removable, custom-built appliance for young children 4 to 10 years. You can see, free stuff here. You can see how, we bend wires and solder. So this is all in part of some of the advanced training that I mentioned. So we use this platform.
Okay, like that, because
Anyway, there's an Australian lab technician there. What else? if you want to check out clinical day, so we spent a whole day at Simon's practice in Australia. You see him treating 19 patients throughout the whole day. So if you want to see that, we have tons of free preview. It's a whole day's worth of recordings from a videographer that, came in and followed my brother around the whole day. But instead of flying to Australia to check it out, you can see the videographer, shooting throughout the whole day, 19 treating 19.
Like the selfie.
You can see
selfie.
how the
take
how Sophia, the
things with
registered.
my iPhone, but I do like photography, so
Anyway, so you can see how what happened throughout the whole day. Treating an 8-year-old here, Alice. So
Over bite and over jet. Can you bite your teeth together? Lips together?
anyway, you get the drift. That's clinical day. And then everyone's always interested in the case study vault. And this is where we've tracked 5 years of data, 5 years of mentoring, dozens and dozens of students like Dr. Dutton, who joined tonight. And we've collected a database of almost, I don't know, it's over 300 now. I've lost count, of cases that were supervised. So if you're a mentoring student, you submit 2 to 4 cases every 2 weeks. You can see it's every 2 weeks, and Simon spends 4 to 6 hours with these students over the weekend. Back in 2021, we only had a handful of students from around the world. Lockdown, COVID,
just a very short job.
So what can we do? We could still mentor. We could still train people through the virtue of good old Zoom. People would submit photos, x-rays, Ceph analysis notes, and they would be supervised throughout the 12 to 18 months of treatment and get, spectacular results. You can see the entire database. If you were to join our program, obviously you get access to it. We got different levels of access.
Yeah.
But anyway, but we've got a very comprehensive program from self-study to you'll get your handheld through case supervision over 12, 18 months and so on and so forth. So the advanced training is just on straightteachnaturally.com/advanced. But we've recently just decided to release about 10 hours of free training in relation to the advanced mentoring and training courses. Alrighty, it's getting late here in New York City, almost midnight. Oh, not quite. That's about it. Any quick questions? Otherwise, I'll wrap up. We're here every 2 weeks for a free Q&A, whether you're a paid student or mentor student or just new to all this. Feel free to join us. Any quick questions, Dr. Viet or Malika?
No, Mr. Ken, and I'm very grateful to attend today because that's very good lecture from Dr. Simon Wong.
Thank you. All right. I'll send you the invite for this weekend shortly. All right. Cheers. Thanks so much, everyone. Good night.
Thank you
Bye-bye.
so much. Bye-bye.